to our visiting professor lecture. Thanks for joining us. If you're in a place where you're able to turn your camera on, and participate, please feel free to do that. I think it's always nice as a speaker to see some faces. So obviously the Scanlon conference room, we can't, but if any others are able to, please feel free. I'd like to very much welcome Dr. Burgan, Constantine Burgan here, our visiting professor today. This is kind of a neat initiative set up through the AUR to match up folks with visiting professor opportunities and institutions. So I think it really is kind of a win-win program. So we're very excited to be participating in that this year. So Dr. Burgan is joining us virtually today. Welcome, Dr. Burgan, virtually to Milwaukee. As we were just chatting beforehand, we're sitting at 30-some degrees, which is not too bad. Dr. Burgan's at University of Alabama in Birmingham. And a couple of positions that he holds is he is chief of ultrasound and also of abdominal intervention at his institution. He's an assistant professor of radiology and also serves as an assistant program director for the diagnostic radiology residency. Dr. Burgan's talk today is, let me get the title here. So be specific. It is Demystifying the Thyroid, TIRADS, FNA, and everything in between. So we're very excited to hear about that topic. And if you want to enlighten us on any of your other background, Dr. Burgan, please feel free, but I'll turn it over to you and welcome. And thanks very much for joining us today.
Oh, that sounds awesome. Well, thanks for having me. I'm really excited to be able to talk to you all today. It's it's unfortunate that we can't do these things in person these days, but the way of the world, and we'll zoom it up. I was mentioning that it was actually somewhat chilly here for a change, and so that's very unusual here in Birmingham. So it'll be 60 tomorrow, so I'm taking care of the sweater weather while I can. So let me get my screen shared and we'll get going. Okay. Can everybody see me okay? Okay.
Yes, looks good.
Perfect. So today as Dr. Homewater said, my name is Kaz. I'm one of the abdominal imagers here at UAB. I kind of wear a few hats these days. So one of the things that has always given people a little bit of a trouble point is the thyroid, and it's a very common exam that we're having to deal with these days, and it's something that I think sometimes people struggle with, sometimes people find a little bit onerous at times, and so hopefully we'll try to find a way to make things feel a little bit less so by the end of this. So I have no relevant disclosures. So why do we talk about the thyroid? Well, as I said, thyroid nodules are super common. We're generating more and more scans every year. We're generating more and more follow-up reports every year. And so if we don't have any type of reproducible system to deal with this, it's really hard to figure out a confident way to grade these things from year to year. So what we'll talk about today is really briefly talk about some of the epidemiology of thyroid nodules and thyroid cancers. We'll talk about how we do a complete thyroid ultrasound at UAB. We'll discuss specifically the ACR TI-RADS system for characterization, because that's the one that we sort of favor and have used over the years. And we'll talk a little bit briefly about some best practices in thyroid FNA. So thyroid nodules, as we said, super common. The initial Framingham data from back in the day was a very, very low estimate. They had upwards of 1 to 6% based on that data, and the incidence is dramatically higher. If you look at autopsy reports, we see these in at least 50% of people, and some of the more recent data suggest it's almost 70% of folks that are going to have thyroid nodules. The older the patients are, the more likely they are to have thyroid nodules. There are some associations that we'll see: smoking, obesity, etc., but we don't typically sort of try to assess people with the risk factors. We're mostly just looking based off of clinical scenarios in these patients. So what are we looking for? Well, we're looking to try to figure out whether there's a thyroid cancer or not. And all those initial surgical series that we had, again, back in the day, suggested that much higher percentage of malignancy in these thyroid nodules than what we actually see. They saw potentially upwards of 40% in nodules. Now, as ultrasounds have gotten better and we've gotten more specific in diagnosing these, this has come down quite a bit. We see rates of anywhere from 5 to 14% in some of the newer studies. When we start to include all the nodules that we're finding these days, it's probably nowhere near that upper number even. We're probably closer to around 10% or less with what we're finding these days. Good news about thyroid cancer is even if we find it, the majority of the cases that we find are going to be well differentiated thyroid cancers, usually a papillary thyroid cancer or follicular cancers. These typically have a very good prognosis, especially in younger patients. But there's a small proportion, 10 to 15% or so, that have a little bit more of an aggressive behavior, even in that differentiated camp. What are more common are what we call papillary microcarcinomas, or something that's less than a centimeter. These are less likely to be clinically relevant. They're more indolent, small little cancers, and they can typically be actively surveilled without necessarily pursuing, very unlikely to present with more advanced disease. So thyroid cancer has a split epidemiology, so we see it in younger patients and we see it in older patients, and not quite as high of a risk in the sort of middle age range. We see it more in patients who have had head and neck radiation, and in patients with big kind of multinodular goiters with a bunch of nodules, the frequency of cancer is actually much less. It's somewhere around 50 to 60% of that, which we see in somebody who just has a nodule or two in their thyroid gland. The large majority of these are going to be treated surgically. And depending on the tumor size, that's what determines whether they're going to get a lobectomy or a total thyroidectomy. Typically, we use around 4 centimeters for a cutoff in a non-aggressive tumor, but this can depend on sort of your institution and what they prefer locally. As to whether the cervical lymph nodes get dissected, that also is a little bit of a controversial local difference. Generally, when we're doing a thyroid ultrasound, we see positive nodes on one side or the other, that will typically sort of make them go ahead and just do that nodal dissection. But in a central dissection, it's pretty controversial. So the ATA guidelines will say you should probably do one if you see obvious cervical adenopathy in that location, or consider it if these patients have, more advanced primary tumors, or if they have lateral neck nodes. So you can see it depends on your institution. I've practiced at places where they sort of prophylactically centrally dissect, and then here they don't necessarily do that if they just have lateral nodes. So how do we do thyroid ultrasound here? Well, the best practice is going to be to use your highest resolution linear transducer available, because these are small parts organs, they're close, they should be nicely visualized with that. Here we're a Philips shop, so we use the Philips EL184 probe with the Epic machines here. And what you're going to do is you're going to size both of your thyroid lobes in 2 measurements, and then we do clips through the entirety of the lobe, in the trans and the long, to be able to get a full sense of what that whole gland looks like. As we'll talk about a little bit later, we will troubleshoot with the hockey stick transducer. So that actually gives us sometimes some better visualization of some of the small little foci that we're looking at and trying to figure out whether they're truly there. Our sonographers are going to look at these nodules, and they're kind of facile with the TIRADS system, and so they'll understand which are going to be measured and which aren't. And then we'll get 2D measurements in the transverse plane and then also the long axis, if they're going to be measured, and then we'll also get focal clips through those nodules. We measure the isthmus thickness as we transition between sides, and then we do finally a color Doppler image of both lobes. So we're just looking to see if there's any hyperemia or kind of significant change throughout the lobes, to think of a thyroiditis or something like that. We do look at the cervical lymph nodes on all of our thyroid ultrasounds and all of our neck ultrasounds to be able to look at levels 1 through 6, 6 being that sort of central compartment. And we'll do a cine clip through there and then take single images to sort of document each level. And then certainly if anything looks positive, they'll be measured and evaluated. If you have a patient that has a mediastinal thyroid extension or a big thyroid nodule that's going inferiorly, you may need potentially to reach for an abdominal curve transducer, and then potentially like a curved type baby head probe, sort of like a C8 level probe, can be used as well to potentially kind of dig a little bit deeper into the mediastinum. So as Conan asks, what is best in life of the nodule grading systems? There are quite a few. I'll focus on 2 here today. The primary that we're going to focus on is the ACR TI-RADS. You can see lots of different countries have their own guidelines. Oops, we went back. The other ones that we tend to use in the US would be things that come from the endocrinologists and the ENTs. They sometimes like to point more towards the ATA guidelines, although here we've sort of gotten everybody kind of on the TI-RADS ship. The most recent one that we see is out of China. The TIRADS system is the latest that was published a couple years ago. Doesn't have as much comparative literature to it, but that's one I'm kind of keeping an eye on, just because that it seems like that may reduce biopsies even further. And the question is where we're going with this in the future with all these different systems. There's an international thyroid nodule working group that's trying to put all these things together, get radiologists, get ENTs, get endocrinologists all together, and basically try to get a coalesced system with all these. And the sort of working title with that is TIRADS at this point, but so more of that to come. So when we compare all these different systems, there's lots of different recent literature that does this, but what we're looking for is, what trade-offs do you want? None of these systems are 100% perfect, but what the literature shows is that the TIRADS system, it seems to perform the best at identifying truly malignant nodules, and most importantly, we're biopsying the lowest amount of benign nodules and sort of reducing what they call the unnecessary FNA rate. So what you want to do when you have all of these smattering of nodules that are coming across your workstation is you want to make sure that we're only following and sampling the ones that we really need to sample. So that's where I think the TIRADS system is the strongest and kind of where it's shined for us. So the TIRADS system initially was finally released in 2017. It does use some higher FNA size thresholds for some of the other systems that we've seen. And this is because as we look at the curves as we go up, and as we cross over around 2 to 2.5 centimeters, which is typically above where some of the other systems recommend FNAs, there really wasn't much of an increase in risk of distant metastasis, meaning kind of more advanced disease. So they felt comfortable kind of once they got past a certain point that they could use 2.5 centimeters as sort of their highest cutoff for some of the grading throughout the TIRADS system. This is a pattern-based system, so it's going to focus on the patterns and assign points based on those. We'll talk about that in a second. We will score these nodules from TR1 to TR5, and the cancer risk in each of these levels, it's going to go up, each bump. It's hard to get a specific rate based on these. It varies significantly based on the study. You'll see a significant jump at TR4, even though it's not huge. And especially TR5, you'll see, some as high as 50 or 60% once you grade up the nodule enough to get to be a TR5. So this is sort of the 10,000-foot view of what the ACR TI-RADS system is, and they've released another chart that can sometimes simplify it, but I like this one for just sort of overviewing the whole system. As you can see, as with the other sort of blank RAD system, we're grading from a 1 to a 5, and we're getting points that put them in each of those different categories. A TR1 is benign. That's going to have no FNA that is required. That's basically simple cysts. A TR2 is what we call not suspicious. So these are typically just kind of mixed solid and cystic nodules that don't have any other concerning features. And then once we move up to 3, 4, and 5, that's when they start calling these things blank suspicious, whether it's mildly, moderately, highly suspicious. And then our FNA thresholds are going to be 2.5 centimeters, 1.5 centimeters, and then 1 centimeter. And then we're following at 1.5, 1, and 0.5 centimeters. So we'll go on and we'll sort of talk about sort of how some of this system works, and we'll understand all these different categories as we go forward. So first is composition. So this is basically, is it cystic or is it solid or is it a mix? And if it's a fully cystic nodule, keeps wanting to go back on me. If it's a fully cystic nodule or a solid nodule, that's pretty straightforward. But when it starts to add one or the other into it, it makes it a little bit less specific. So what the standard is through the TI-RADS system is actually 95% of whichever you're talking about. So if you're going to call something almost completely solid, it should be 95% solid. If it's almost completely cystic, it should be 95% cystic. And the first tip here is to make sure you're using your cine clips to evaluate the whole nodule for makeup. So if you're looking at a single image of a nodule, it's really hard to use that to 100% determine what the makeup of the nodule is. You can use the clips to be able to go back and forth and really assess that whole thing and make sure that you're comfortable with what the composition is. If it's not pretty close to 95%, you're usually pretty safe to call it mixed solid and cystic. There are some special categories in composition. So there's what we call spongiform nodules, which are essentially if you cut a cross-section of a sponge, you have a bunch of teeny tiny little cysts in a nodule. If we see this, and you'll see an example of what that is in a minute, then you can essentially stop grading at this point. There are some people who feel like you can't have anything else in a spongiform nodule. So if you have a calcification, it's not a spongiform nodule. This is sort of an argued point, but nonetheless, it seems like most folks, if we have a spongiform characteristic, we'll typically just call them a TR1 and call them benign nodules. Now, if nodules are so calcified that you can't tell what the makeup is, we give them 2 points because we're essentially assuming that they're solid at that point. So in this case, that's what that looks like. It's so much shadowing that we can't tell. So here's solid and almost completely solid nodules. You can see here's an isoechoic nodule with no cystic component within it. It's just purely solid material. Whereas we look to the nodule to the right, you can see there's a small little cystic space, but not enough to really make up more than 5% of the nodule. And you can see on this clip here, as we sort of scan through that nodule, you can see there's little blips of cystic spaces here and there as we kind of go back and forth. But again, probably less than 5% of the overall nodule composition as we go through it. So that's almost completely solid. On the flip side, this is a purely cystic nodule. Now, this looks like its echogenicity is a little bit higher, but it's because, as we'll see on this clip, you have a lot of little comatose artifacts that are going to show a colloid appearance throughout this nodule. So in this nodule, there's no solid material as we go through it. All we see are those little comet tails, and that's pretty characteristic of colloid material. Nothing here that looks like it's solid within it. And these clips really pick up that comatose artifact a lot better. You might be mistaking these for sort of little punctate foci, but as we sort of scan through, we can see that the majority of those are going to be comet tails. The next category is almost completely cystic. So this is a nodule that looks predominantly cystic here, and we don't see much solid material, but we just see a little bit of scant stuff around the periphery. And as we scan through it, again, we can see that there's no big bulky component. The large majority is going to be cystic, and that's consistent with an almost completely cystic nodule. Mixed solid and cystic is another category that has pretty benign features. It tends to not have, has a nice mix between the two. These nodules here are around 50-50. The echogenicity when you're grading them is going to be based on sort of the solid component of the nodule. But here we see just basically a nice, well-distributed solid component throughout. There's nothing here that looks eccentric or kind of worrisome. It's just sort of nicely distributed throughout the nodule, and that's kind of what we're looking for. Again, here we have sort of a similar look. It looks maybe a little bit more solid material anteriorly, but again, nowhere near 95% of each individual category. This, we'll come back to this in a second, but this was a little comet tail focus that we were able to pick up better on a Cine clip later, and I'll show you why that might be important. So here's the spongiform nodule. This is sort of the characteristic classic spongiform nodule, a bunch of teeny tiny little cystic spaces all throughout, and no real appreciable, significant amount of solid tissue. Maybe there's tiny little islands of little bits of solid stuff, but almost all of this is going to be these little tiny cystic appearances. Now, this is a little bit controversial. Technically, these nodules over here through the TIRADS categories would not be technically spongiform. You can see there's a couple little, what looks like spongiform appearance in the center of the nodule, but a big chunk of this nodule here has a more of a solid appearance. So I think this would be better characterized as sort of a mixed solid and cystic, or even potentially an almost completely solid appearance, just because it doesn't all kind of look like this. This nodule in the inferior portion here is a little bit more of a toss-up. You can see larger cystic spaces. Some people say that doesn't qualify for spongiform. I would feel comfortable calling it in that if the rest of the nodule looked like that. So this is a little bit more indeterminate, but again, a little more solid material than one would think with sort of the classic spongiform. So you move on to echogenicity. And again, this is one of those categories that seems like it should be straightforward, but has its tricky elements. So if something is anechoic and it's completely cystic, it doesn't get any points. If it's isoechoic to the thyroid parenchyma, or it's a little bit brighter than the parenchyma, that gets a point because those are typically more benign type features. If it's hypoechoic to the parenchyma, it gets 2 points. And if it's very hypoechoic or darker than the adjacent strap muscles, it's going to be up to 3 points, because the darker it gets, the more and more suspicious it is. If you can't tell the echogenicity for one reason or another, you just grade it as 1 point and kind of leave it at that. The cine clips, again, are very, very helpful in this circumstance. There's sort of a tendency to want to use the quote unquote worst echogenicity, that or the most suspicious echogenicity, because nodules can look hypoechoic when there's a bunch of cystic material in these nodules. So using the clip to go through and trying to isolate that solid material within the nodule, that's what you really need to do to associate whether something is truly hypoechoic or not. Overall, that you can just drop the overall echogenicity because of some overlying cystic component. So you want to be able to look at that in its entirety. So this nodule on the left here is the same one that we looked at earlier because it was a nice example of what an isoechoic nodule looks like. You can see it's equal to what that parenchyma is. Whereas this from the radiology assistant shows what that hyperechoic appearance can look like. It's just brighter than that background tissue. On the contrary, where we have hypoechoic nodules, again, we have that sort of semi-bright thyroid parenchyma, and then a dark appearing nodule in relative to that. In this case, we have a very hypoechoic nodule. You can see this is much darker than the adjacent parenchyma, and it's actually darker than the anterior strap muscles here. And this nodule even looks like it's got some potentially extrathyroidal extent, which is another suspicious feature that we'll talk about in a minute. But it all just sort of adds up to a more suspicious nodule in this case. So we'll talk about shape. And shape is basically, does something meet the criteria for what we call taller than wide? And this is a term that you might hear in the breast cancer world as well. It kind of denotes an aggressive lesion. And the reason is that the thyroid typically has a nice drapey appearance laterally, and that's the normal sort of expected tissue plane of the thyroid. When something is taller than wide, it's growing more aggressively in the AP plane than the other planes, and it's essentially not respecting those normal tissue planes at that point, so it's more aggressively growing in that way. The way that we best assess this is we get a single transverse image at the mid portion of the nodule and try to see what that nodule is shaped like. And we're doing this primarily based on kind of a visual inspection, so kind of like Gestalt fashion. One of the tendencies is people want to try to call things taller than wide based on being just a couple millimeters greater in the AP size dimension. You're going to overcall a lot of taller than wide nodules doing it that way. If you're not sure, if you're kind of hemming and hawing and you're thinking maybe it is, look at the long axis measurement. If the long axis measurement is much longer, then it's probably not going to be taller than wide because it is at least growing in that fashion where it's growing with the gland rather than just against it. And so I'll show a couple examples of what this looks like and then a fake out that we see. So here's an aggressive, kind of ugly, taller than wide nodule. This was actually a fairly aggressive thyroid cancer, but here you can see that this is pretty significantly growing in the AP dimension. It's bulky, obviously, in the transverse dimension as well, but it's more growing AP. You can see some areas where it looks like it might be coming outside of the capsule. There's some calcification centrally in it. This you can just look at and say, okay, this is taller than wide, greater than AP dimension. This is a smaller nodule where it's a little bit tricky because if you look at the transverse image, you might not want to call this one taller than wide. You look at it and it's no, that's kind of a rounded looking nodule. But actually in this case, when we switch to the long axis, you can see that it truly has that kind of oblong appearance on the in the AP dimension. There may be potentially some posterior or anterior, capsular involvement here. And here we can actually get a measurement that looks like it's truly taller than wide. So sometimes the nodule, the long axis is a savior, and sometimes it's kind of a confirmatory setting like it was in this case. But then on the flip side, we had a nodule like this that looked kind of suspicious. And so when we first looked at this transverse image, we thought, oh, it's measuring pretty equal, but are we potentially missing something? Could the nodule itself be a little bit longer? Could this really be taller than wide? And when we look at this, the margins are kind of ugly. It's a little lobulated. It's not like a nice smooth thing. So this met our size criteria to be biopsied anyway. So we went ahead and biopsied this, and this ended up being a benign nodule. But this shows you that how much longer that this is in the long axis, that this was truly not a taller than wide nodule, but it did have some other potentially concerning features. So that's just one way that you can kind of get out of calling something taller than wide if you're not convinced about it. So when we talk about margins, I just mentioned on the previous case to kind of lead into this, this is kind of anecdotally, it's the the least likely category where I'm going to add points for the most part. Most of these things tend to be smooth or ill-defined, and they don't get any additional points in this category. What you can have is you can have either lobulated or irregular margin. So the lobulated margin here is where you have a little focal protrusion of tissue that comes out. And again, this is a lot of these concerning features tend to coincide. You can see that this, again, has some potentially extracapsular involvement. And then here on this irregular one where you have these little more sharp angulations and potentially even little spiculations there, this also has extrathyroidal extension. That's an irregular margin here within the thyroid. And what we mentioned here is obvious extrathyroidal extension is a category. Within this category, we'll give you 3 points. So if you have where it clearly juts out of the thyroid and it invades the anterior or the posterior tissues, that's going to be a 3-point thing. And I will say that if you see this on something, you're probably going to be, even if you got a benign biopsy result, I would probably highly suggest to the surgeons that they consider taking these out anyway, just because we rarely see this type of feature in a benign nodule. So here's another example of extrathyroidal extension. This is a sort of an oblong nodule that looks like it wants to sort of behave. And then when you get to the anterior margin, it really just juts out. The thyroid capsule does not go with it. It basically just breaks through. And this is not just a nodule that's just universally enlarging and pushing that margin out. It's really invading through. And that's what extrathyroidal extension looks like. So finally, there's the category of echogenic foci, and this is the most unique category because it's not an additive category. It is an additive category. It's not just to pick one. The others, you basically pick one of those points and then you move on. This you can grade up a ton of points in a nodule based on how many of these features that we're seeing. And one of the things that we will see, pathologically and potentially sonographically, the most suspicious characteristic to suspect a papillary is what we would traditionally call macrocalcifications. Now, it's often hard to figure out whether something really teeny tiny is a true calcification or if it's some other reflector that's causing that to appear. So in this system, what we call these little foci are called punctate echogenic foci, and these are 3 points in the TIRADS system. These are not definitely equivalent to microcalcifications. If you look at the positive predictive value just for these PEFs that we call them, it's about 48 or 50%. So it's not the same, whereas if we knew it was a microcalcification, it would be much, much higher than that. But whereas all microcalcifications are punctate foci, not all punctate foci are microcalcifications. We can have other types of calcifications that show up. So bigger shadowing macrocalcifications get another point added, and then rim calcifications along the periphery will be 2 points. They may or may not shadow, kind of depend on the case. Now, there's something that are called comet tail artifacts. We mentioned it earlier. If they're big comet tail artifacts, these are a V-shaped sort of reverberation artifact that we see. That's really commonly seen in colloid nodules in cystic components. And if we see it, it's large, it's greater than 1 millimeter, we can consider it a benign feature and grade it as such. If they're smaller, if they're less than 1 millimeter, or if we definitively see them in solid component, we have to sort of assume that those are punctate echogenic foci because some of those do have comet tail artifacts, and we grade it as such. Now, does that mean it's definitively a cancer? No, it doesn't, but we have to sort of grade it up a little bit higher. If you're having trouble figuring that out, often our sonographers will come in and we'll have things where we're kind of like, I don't know if that's really a PEF or if it's comet tail, I can't tell. If you put a hockey stick on there, that will actually sometimes really pick up whether that's a true comet tail artifact or if it's a punctate focus, and we need to kind of go from there. We've had situations where patients come in for a biopsy and they didn't do this on the, the pre-procedural diagnostic study, and we put the hockey stick on to do the FNA, and we're like, oh, okay, there's a bunch of comet tail artifacts, but it's kind of hard to get out of biopsy once it's been fully recommended. So here's some examples of what these look like. So rim calcification, this is a nice example of that. It's just basically calcification along the periphery of that nodule. This one happens to shadow, although they do not have to. Macrocalcification is what we see on the right here, big bulky calcification with lots of posterior acoustic shadowing. In this case, it's partially obscuring the nodule. You can imagine if it was totally sort of under here, you wouldn't see any of it, but we can also in this case, see that it is a hypoechoic nodule, and we could effectively grade the echogenicity with this case. Here are some examples of punctate echogenic foci. These little tiny foci all scattered throughout this hypoechoic nodule. Some of these could be in cystic spaces. As we can see, there are a couple little tiny cystic spaces here, which are probably a little posterior reflectors or acoustic, through transmission that we're seeing here. Some of these are not 100% definitive. They were a little bit concerning. When we biopsied this came back as a papillary thyroid cancer. This is an example of one that's in a little bit more of a solid nodule. You can see as we scan through it, there's lots of little tiny punctate foci all throughout. There's actually a macrocalcification in the center of this nodule as well. So you get the 3 for the punctate foci and another 1. So you get a total of 4 points from this category from what we see. And this was also a papillary thyroid cancer. When I talked earlier about comet tail artifact, I mentioned in our mixed solid and cystic that we had one that we weren't 100% sure about. And you can see in this case, the cine clip shows us that this is truly a large comet tail artifact. As we scan through it, we couldn't really tell based on that single image, but when you look through the clip, you can really see that little comet tail coming in. It's shaped like a V, it's bigger than a millimeter, and we can confidently just say that that's a nice little cystic space, and this was a benign nodule associated with that. So this is just one of the utilities of the cine clips that we have. So now that we talked about how to grade these things, how do we report them? Well, the TIRADS system recommends that you limit your total number of nodules to 4, and that's with the ones that score the highest. So it's not just like 2 on one side, 2 on the other. If you have 3 that are suspicious in one gland and then 1 on the other, that's okay if they're grading the highest. What I recommend doing is reporting the score and avoid using the blank suspicious characterization. I feel like even, with how low the cancer rates are with TR3 nodules, even calling them mildly suspicious is sort of something that's just going to put a bug in the patient. It's going to put a bug in the referring clinician, and they're not going to want to, just handle that by itself. They're going to say, well, you said this was suspicious, and it leads to issues. I would just sort of report it and give your recommendation. It's also really helpful to report these in a structured fashion. So we have these, all in a structured report. We show how we're calculating all these points, and it helps us be definitive and sort of repeat how we do this. There's no definitive recommendation in the system for nodules that have been biopsied previously. So I tend to not make a lot of recommendations in terms of follow-up, et cetera, with these. It's a little bit tricky to figure out what to do with those. Certainly if they look more concerning, you could, recommend additional follow-up or another biopsy if you're concerned about them. So in terms of the follow-up and growth, sort of what do we do with these over the course of time? So TR3 nodules, if you look at the white paper, they recommend follow-up at 1, 3, and 5 years. I would say until recently, they had not been doing this at our institution, but we've tried to become more judicious at recommending they skip those 2 and 4 years just to try to lighten the load a little bit. The TR4 nodules add another follow-up at year 2, but skips year 4. I will tell you that sort of practically it's hard to implement a 1 year off of a thing. So for the most part, for these TR4 nodules, we're going to recommend that they do it every year, despite that it doesn't exactly follow that criteria. And for TR5, the most suspicious nodules, we're going to follow them at least once a year for 5 years. At 5 years, if there's no big change, if they're stable, you can stop at that point. But if grading changes, so if grading increases, as it sometimes will, if it develops a punctate focus or something like that, if it doesn't meet criteria for biopsy, we'll do an additional follow-up at least. Or if at some point it grades up enough that it does meet FNA criteria where it didn't previously, it was only follow-up, then that merits performing an FNA at that point. Growth technically is going to be a 20% increase in at least 2 dimensions of the nodule, or a 50% increase of that entire nodule. So when you're assessing for growth, make sure that you're looking at your remote priors too. So don't just stop at 2021 when you're looking at a 22 study. Make sure you're going back to 18 or so, and that you're not missing growth that has really happened over time. So like any system, this system has some caveats. There's some exceptions. And one of them is in mixed solid and cystic nodules. And there can be the nice sort of well-differentiated kind of smooth nodules that we looked at earlier that has some just kind of clot, debris, things like that. versus true solid material. And if it looks more eccentric, if it's sort of trapped on one side of the thyroid, that can be more suspicious. And this is, even though we don't recommend color Doppler imaging on thyroid nodules to try to grade them as they have in the past, this can be helpful to tell you whether something is actually vascularized tissue or not. And you're going to look for those suspicious features in those solid components. But when you're grading these, make sure you're grading on the size of the entire nodule, so the cystic component included. You're not just grading based on the size of that little solid component. So here was an example of kind of a suspicious looking eccentric nodule. Now this would, be mixed solid and cystic, or even potentially almost completely cystic. But we had this sort of really hazy looking, really eccentric nodule that, had some little spiculations at the periphery. We put color on to see if there was flow in there, and there was not, but we were suspicious enough that we went ahead and performed a biopsy in this case, just because of how, kind of ugly that looked. Unfortunately, this one was benign, but occasionally we will see things like this that can turn out positive. In this case, this was also this did not grade up to require a biopsy, but you can see here, this is a mixed solid and cystic nodule where at the periphery, you can see some vascularized solid tissue in there. So if this was high enough, this might have, potentially garnered some follow-up at some point, but fortunately, this was fairly small and did not require that. So small nodules are also something to consider. So if you have it that doesn't quite meet FNA criteria, depending on the clinical situation, it might actually merit doing an FNA to sort of try to put something to bed or not, because shared decision making with the patients and the referring docs always applies in these cases. And this is an example of where we did that. So this is a nodule that is very small. This is a 6mm nodule. And I know we said, we talked about, don't just say it's taller than wide based on 2mm. Well, in this case, when your nodule is 6mm, 2mm actually does make it look taller than wide. So in this case, it was a quite hypoechoic nodule. It actually was taller than wide, and we did see some punctate echogenic foci within the nodule. This is a patient that lived multiple hours away. It was sort of unclear if they would follow up. So we went ahead and did the FNA in this case, and this was a very small papillary thyroid cancer. So this would fall under sort of the microcarcinoma look for this. So this patient may or may not have gone for a thyroidectomy. They could have considered follow-up, but this is just a case where it might be useful just to kind of put things to bed. So the last thing to talk about in these circumstances would be a post-biopsy appearance. There's this phenomenon called the mummified nodule, where after a thyroid nodule gets biopsied, it all of a sudden looks a lot more hypoechoic and it starts to get calcified. And this is actually not a concerning appearance, but you can imagine if you came into the picture late and figured it out, it starts to look more concerning. We know that this happens, but this is probably going to end up at least prompting probably another biopsy. But just know that once something has been sort of violated with a needle, it can potentially end up looking like this. And you can, if you know that it's been done, you may get away with just sort of some close interval follow-up. But ultimately, for the referring docs, you're probably going to end up having to put a needle back in this just to prove that this is not significantly changed. Now here we've started to see some of our ENT doctors start to do RF ablations on some thyroid nodules. They're not doing this everywhere, but here they're doing it basically for bulky nodules in patients who are not good surgical candidates. So we may start to see this used more for cancers as well. This is used in some centers for cancers. But presumably we'll start to see some of these similar features, more hypoechoic appearance, calcifications, et cetera. And I know they're doing these at Mayo because this is an example from the Mayo Clinic News of what a pre and post looked like from them. You can see here on sort of, fairly isoechoic nodules, so maybe some cystic, like less isoechoic spaces in it. And once we start to, once we do an ablation, the nodule basically shrinks to almost half its size. It develops a little bit more of a hypoechoic appearance and maybe some calcifications. So just be aware of kind of what's going on in the nodule in the interim if you know it's been messed with. And finally, in terms of our diagnostic look, we always have to take a look at the cervical lymph nodes, and we have to look for concerning features. So What we're looking for here is typically kind of a rounded appearance that tends to tell you that the node is potentially involved, especially if we have a suspicious primary nodule. And then typically within a lymph node, we have hilar flow. So here's a small hilum, but there is a bit of central flow in the node itself. Whereas when we start to look at these when they're more suspicious, they tend to get more flow around the periphery rather than within the hilum. And this was a metastatic node. If you have cystic or necrotic change in a lymph node, that's also a very suspicious feature. This can certainly happen in the setting of infection and things like that. But if you have a known, head and neck primary, any cystic or necrotic change should be met with a lot of suspicion. We mentioned the hilar flow here on this lymph node, but again, what we're seeing here is this big kind of cortical hypertrophy, and that typically bright fatty hilum is starting to get squeezed out by all that hypertrophy, and this one is starting to look more rounded as well. We're maintaining some hilar flow, but if this continued to progress, we might lose this entirely. And then finally, just like in the thyroid nodules, if you see echogenic foci or even shadowing calcifications in the node itself, in the setting of a potential papillary thyroid, that's very suspicious, and we should, consider biopsying these as well. So we'll bite the bullet quick. We'll talk about thyroid FNA, and this is what we're trying to avoid, but this is what we inevitably have to do at some point. So why are we doing thyroid FNAs? Well, it's primarily based on, as we said, the TIRADS scoring methods. So for a 3, 2.5, for a 4, 1.5, and a 5 greater than a centimeter. But there are some other criteria. So like in this nodule here, if you have FDG avidity on the PET CT, it doesn't mean it's a thyroid metastasis, but they can actually pick up, like in this case, a papillary thyroid cancer in that setting. If the patients have a really strong family history or a personal known history of thyroid cancer, if they've had a thyroidectomy bed nodule that we can see, or if they have new nodules when they've had neck radiation, or if a nodule's gotten larger, as we mentioned, with a prior benign biopsy. So all these are potential reasons you might sort of need to sample a nodule. So how many to biopsy? Well, in the average patient, we don't want to biopsy more than 2. There are always exceptions. We have some endocrine surgeons here that just have all kinds of weird crap that they think about, and there's lots of different things that you can see where you might want to do an additional nodule if it showed up on a nuclear medicine scan or something like that. But we always want to consider doing a sampling of the regional lymph nodes if there's a suspicious appearance that we talked about earlier. So don't forget about doing those at the time of the thyroid FNA. So how do we do this? Well, on the day of the procedure, we do a diagnostic study if we have not done one performed locally. And the reason is that, these are very, institution specific, and there's a lot of vagary about how these are performed in the community. So we don't interpret any outside ultrasounds here. We have the patients come in and we repeat a scan on the day of biopsy. And our docs give us the leeway to grade them as we see fit. And, unless there's something very specific they want us to sample, if we don't grade something to be appropriate for FNA, they're comfortable with us sending the patients home in that circumstance. But if we are going to perform the FNA, we need to decide our approach. So we're going to decide whether we're going to do a lateral approach or a medial approach. And this is going to depend on a couple things. So how deep the nodule is and what we're trying to avoid. So, IJs can be of varying size and position with what we see. Sometimes they're really big. Sometimes they're really, posterior and fairly small. Sometimes you have superficial vessels that you need to avoid. One thing that you can do to try to improve your visualization is to do a head tilt. So you want to, essentially try to turn the head on one side or the other, kind of opposite where you're trying to image. And then if you put a towel roll, instead of putting it under their head to support them, if you put it under their neck and let them gently sort of stretch out and extend a little bit, that'll give you a little bit more space. Now, certainly if somebody's had a cervical fusion or something, that's not going to work for you, but it's a possibility to try to improve how much you see. And so what we recommend is using the smallest footprint transducer that's going to allow you for visualization. So we really like that hockey stick transducer that we've talked about to be able to get into tight spaces. But occasionally you need to use larger linear probes to be able to see things that are a little bit deeper. And in the worst case scenarios, what is going on here? In the worst case scenarios, you may need to use potentially a curved probe to get a little bit deeper. We like to go parallel to the transducer, and You can technically actually use a needle guide for things like this. Where I did my fellowship at Hopkins, and they did all of their thyroid FNAs with a curved transducer and a needle guide and a spinal needle, which is kind of interesting, but it does tend to make the procedures very quickly. But you know, it's a local thing, and that's kind of how they did it. So it's an option if you need to. And I have done it on 1 or 2 occasions for like really deep thyroid nodules that were really hard to get to with what we're looking at. So when we do this, we have a cytotechnologist present to prepare the slides. You can certainly do this with a cytologist there. And it's nice to certainly have somebody present to be able to prepare the slides, and also can look at the lymph nodes for flow cytometry in the case of lymphoma workups and things like that. And we have our cytopathologists that are available for what we call a rapid read. Here, we do things as a fine needle capillary action, so we don't use syringe suction when we do these samples. The data seems to indicate that produces maybe slightly better specimens and a higher diagnostic rate. If you need some additional grip, sometimes that small syringe can be a little bit challenging. If you pop the plunger out of the syringe, you can actually attach one on there and just use it for additional grip, if that helps you a little bit in that circumstance. If you're getting kind of poor material, you can try a syringe, but if you're doing that, make sure you're using fairly smooth, continuous suction as you're going back and forth. You don't want to try to pull, you know, ridiculously hard and you're probably not going to get as many cells if you do it that way. When we're doing the biopsy, you're going to prep the transducer with the probe cover. We use 1 to 2% lidocaine in the superficial tissues. You know, I try to recommend using no more than about 5 cc's. If you start pouring a bunch of lidocaine in, you can make a really easy procedure into a difficult procedure by distending all those tissues. And you want to try to put it in fairly slowly. Now, it can actually be helpful sometimes to put a good bit of lidocaine in. So if you have like a big IJ that's kind of getting in the way, you can actually do a little hydrodissection type thing where you put a bunch of lidocaine in and it sort of pushes that a little posterior and gives you a better window for your biopsy. To see your needle best, you want to make sure that your bevel is sort of pointing towards the transducer to get as much of the beam on the bevel that you can. You want to use as shallow an angle so that you can, so ideally like 45 degrees or even sort of more shallow if you can, and just use smooth motion. You know, in some of these patients with bigger necks and more echogenic tissues, it can be really hard to see a needle if you're not moving your needle. So make sure that you're, you know, fairly smoothly moving back and forth. Coated needles are an option if you're not getting good visualization, but you know, we typically don't need to use those in most cases. So here, so how many passes do you do? Well, it kind of depends on how, you know, what you have. If you have somebody reviewing your images, you know, in real time, you can, you know, do 2 or 3 usually and get away with it. You know, here we don't have, you know, the ability to be able to have somebody here on every single case. So we do an astronomically high 6 passes. You know, we get accordingly very low non-diagnostic rates. So you'll see anywhere from 2 to 30-ish% in the literature, with around 1% for real-time slide review in terms of the final result being non-diagnostic. We get kind of around that rate with what we do anyway. The 25 gauge needle tends to be sufficient. You might get a little more cellularity if you increase your gauge, but you also get more blood when you do that. So it's kind of a little bit of a catch-22 at times. What we routinely do is we, on all of our thyroid cases, unless the docs don't want it, is we do an additional 2 passes for some molecular sequencing in the case of kind of an indeterminate result. So here's just kind of a nice example of what a classic thyroid biopsy looks like. We have our needle position, you know, at about 45 degrees. Our bevel is positioned up. We have nice echoes coming off the nodule, and we're just kind of making smooth passes back and forth. We're trying to get as much of the nodule in each pass as possible. Some people are convinced that you need to kind of like jackhammer a nodule to be able to get any type of cells from it. I'm not a believer in that. I feel like I tend to mix up my speed as I go through, and you can go fast, you can go slow, but the big thing is to make sure you're getting as much of the nodule as possible. So when we get thyroid cytology, just to finish up, we have this Bethesda classification system that they use. It's mostly straightforward, whether it's non-diagnostic, benign, you know, if it's malignant, the risks are fairly well laid out. In this 3 and 4 categories where we have these lesions of undetermined significance, or potentially suspicious for follicular neoplasm, we get these very big cancer ranges. For me, it's a big difference whether somebody has a 10% risk of cancer or a 40% risk of cancer. That's going to change things a lot. So what we can use in these circumstances is molecular genomic testing that I mentioned. And these are sometimes hit or miss, but I think they can be helpful. So what we use the Afirma at UAB. They're really nice because they tend to give, what the results give you is either a benign or a suspicious camp. And they have a great negative predictive value. It's pretty darn high. So if it comes up as benign, you can be really comfortable with what you're looking at. However, if you get a suspicious category, no matter what system you use, this compares the Afirma with the ThyroSeq system. And you're getting in the 50 to 60% positive predictive value. That's not as high as one would like if you're talking about taking a thyroid out. So you really have to kind of go back to see how suspicious you were to begin with, based on what you're looking at. If you're looking at an ugly TR5 nodule and you get a result like this, you're probably going to want to take it out. But if you had a TR3 nodule that was looked pretty darn benign, it didn't have any suspicious features, then you might consider just monitoring that or being a little bit close with it. But these panels often have some of these mutations that go along with them now. So a BRAF mutation is basically exactly consistent with malignancy in these cases. And then, RAS mutations are ones that also significantly bump up the risk of malignancy. So if we see these in one of these panels, that might be an indication to pursue a thyroidectomy for these patients. So a couple complications that we can see with thyroid FNAs, none are very common. The most common one is discomfort. Occasionally you'll get patients that will kind of vasovagal in these circumstances, but by far and away, discomfort is the most common. Just a couple funky complications to finish out. Sometimes we'll see bleeding inside of cystic nodules. Here's a nodule sort of pre-biopsy, and then after the biopsy, you'll start to see some layering hemorrhagic material. We see this not uncommonly in a mixed solid and cystic nodule that will biopsy. All of a sudden, it just looks more solid than it did at the beginning of the procedure, and that's typically what happens. Occasionally, you'll see some extravasation. Again, we use such small nodules that this is not as common with a 25 gauge, but again, in this case, we did see a tiny little jet, and we were fortunately able, because of where the thyroid is, to compress this, and then you can see that basically goes away after a few minutes of compression. One thing that you'll rarely see is this was actually a pseudoaneurysm from a thyroid FNA. You can go 3 careers and probably never see this, but this was actually a case they must have just been a tiny little vessel that got in the way of where they were, and they just nicked it. And you can actually see that classic swirling appearance from a pseudoaneurysm that we saw in this. You can see how old this is. This is from 2005. I don't know if we've had any of them since then. I sure hope not. But I don't know if this one was compressed or if it was injected or what they did with this. But really, really uncommon. So again, fairly risk-free procedure for the most part. So in conclusion, thyroid nodules, as we said, very, very common. We see them quite a bit. We see tons and tons of follow-up for these. So we wanted to pick a system that would help reduce the amount of times that we're doing follow-ups, the amount of times that we're doing FNAs. And the TIRADS system really does that. It reduces the FNAs and the system burden. When you get used to it and you kind of apply the rules, it's pretty easy to use. It's flexible. And when you're comfortable with the decision point, it's easy to implement in a practice. The sonographers are a big point in helping with this as well. They're sort of the lead point for all these things where you can really help implement this. And if they're comfortable with it, then the radiologist will be more comfortable with it as well. And then FNAs, if we standardize sort of how we do it and we do molecular testing, we can really improve the results from that and hopefully just kind of get better outcomes for the patients that are getting these FNAs. So with that, I appreciate your attention, and I'd be happy to take any questions if any came up.
Thanks, Kaz. That was outstanding summary of both the diagnostic and with those tips and pointers, very useful, and also the procedural components. So yeah, very nice summary. Thank you very much. Anyone from the group have any questions for Dr. Burgan? One thing I was curious about, Kaz, was it pretty easy to get buy-in from the endocrinologists and the endocrine surgeons? Is it pretty universal that you're all speaking the same language with the TIRADS?
Yeah, I think we are now. I think, with any system, especially one that was, I think they were mostly on the ATA guidelines beforehand. When we were lucky that we're fairly early adopters with this. Franklin Tesler is here, who's who's like the co-author of all of these TIRADS papers and whatnot. So we were pretty early on it, and so getting them in and seeing all the data, that was a relatively easy conversation. But when you're not in that setting, it can sometimes be a little bit tricky. When people are convinced that they must have an FNA at a certain size or a certain look, and you just have to sort of keep at it with data. And then even if they're not 100% buying in, if you're giving them consistent reports and good reproducible things, I think it's helpful in the long run. So even if, as I said, the shared decision making thing always applies. So if they feel strongly about getting something FNA, over time they will eventually come around, but it can be a little tricky. Hopefully the TIRADS system that they're working on will kind of move more towards that and get, also have more insight from surgeons and endocrinologists and whatnot. So they'll have a kind of a universal recommendation. So that'll be helpful.
Yeah, I can, I can say it was definitely like night and day when we switched over to TIRADS. We were kind of all over the map before that, and endocrine was doing one thing and the surgeons were doing stuff, and we were recommending all kind of biopsies and biopsying all these nodules. So we actually had a very nice work group and sat down with the endocrine surgeons and the endocrinologists, and we all kind of talked about our society's guidelines, and we were able to convince them that TIRADS was the way to go. And so everyone just bought in, and boy, it really significantly reduced the number of FNAs that we do, and just so much standardized thing. It's definitely one of the great success stories in radiology. There's so many of these scoring systems that are out there now, but I think this is one of the, obviously ones that really has great impact, in our world of ultrasound. So
yeah. No, you definitely, at some point we start to feel, blank rads, exhaustion and whatnot.
Yeah.
So, it's just, there's so many different systems, and some are more difficult than others to implement. But, ultimately it seems like all roads lead to the standardization that they bring. And it seems to really, especially in thyroid, you can feel the difference.
This one has definitely made a difference for our practice. Yeah. And thanks for all those tips are great. I hope the residents, take a lot from that. I think some of the challenges with the TIRADS is something Spongiform and a nothing, or is it a TR4? Those are hard differentiations. Or is it punctate echogenic foci? Is it really just colloid, or do we give it 3 points? And I think your point about doing the nodules on the cine imaging is absolutely key. So, I think definitely something the residents should take home from that as well. So yeah, definitely.
Yeah, it's interesting that the ACR doesn't require cine clips, and they actually kind of poo-poo cine clips in general in terms of putting these things in for accreditation. But I can't imagine doing thyroid ultrasound now without it, and so it's just one of those things that it is such a problem-solving tool for us that it's I would almost rather not read them than than have those.
Yeah, absolutely. Well, we're coming up on the top of the hour. So any final questions for Dr. Burgan? All right. Great. Well, all right. Well, then final thanks, Kaz. Pleasure meeting you today. And, it's unfortunate it can't be in person, but I think this was a wonderful session, for all of us. And, really a pleasure to meet you.
I appreciate you having me, and participate in the program. It was a lot of fun, and wish I could have come up and met everybody in person and done that. But you got to do with the times what you're given. So so this was fun. I was glad to be able to talk, and hopefully it was helpful to everybody.
Definitely a very nice review. So we appreciate it. All right. Well, thanks everyone. Have a good afternoon, and thanks again to you, Kaz.
All righty. Take care.